Hello and welcome to today's webcast entitled Cost Transparency, How Educated Consumers Are Driving Change. We have just a few announcements before we begin. The slides will advance automatically throughout the presentation. To enlarge the slides, click the Enlarge Slides link located above your presentation window. Should you require technical assistance, click on the Help link. If your screen freezes or the slides do not appear to be advancing as they should, please try exiting and restarting the session, as it may be an issue with the connectivity. At any time, you can submit a question using the Ask a Question box located in the bottom left-hand corner of your screen. I will now turn the call over to Ms. Robin Gelberd, President. Please go ahead.
Hello, my name is Robin Gilbert and I'm the President of Fair Health. I'm delighted to be addressing you this afternoon during this webinar. We look forward to providing you a window into the marketplace from where Fair Health sits, which due to our neutrality and unique origins is right in the center of multiple stakeholder groups. From that vantage point, we can identify trends in their early stages and can also direct resources and talent in furtherance of sound strategic business practices that serve a variety of constituent groups. By developing data products and consumer services that are aligned and robust, we help reduce the confusion, suspicion, escalating cost structure, and inefficiencies that often plague the health insurance marketplace. This afternoon, we will discuss certain trends in the healthcare industry and how such trends are inextricably linked to the need for greater cost transparency. We will also provide you with an overview of our unusual history and valuable data assets. We will discuss the broad industry acceptance we have experienced since our formal launch, summarize our data contribution program and the processes and protocols in place to support our data validation and auditing program, showcase our free consumer website, which was recently honored as a national resource, address the issues emerging between UCR-based and Medicare-based out-of-network reimbursement formulas, describe how industry can leverage our consumer cost lookup tools and educational resources, and detail the various ways in which Fair Health Database is supporting businesses and federal and state governmental agencies. We will, of course, leave time at the end for your questions. As most of you know, consumers are increasingly being asked to take a more active role in managing their healthcare expenses. High-deductible health plans are becoming more prevalent. A growing number of consumers are availing themselves of health savings accounts. And for those plans that have converted to using a Medicare-based multiple, consumers are being asked to shoulder a larger share of their provider bills for out-of-network services. Unfortunately, at the same time that the ground is moving under the feet of consumers, they have been given few tools to help navigate the complex world of health insurance. Indeed, for too many consumers, decisions are being made in the dark about what care to access and at what cost. Often they learn about the cost of certain procedures after it is performed, particularly in the case of consumers going out of network for care or managing their high-deductible plans. The surprise they receive when learning of their responsibility for payment leads to strained relations with providers, plan representatives, and employers, particularly against the backdrop of this economic climate when now more than ever financial planning and sound decision-making are critical. One need only open the newspaper, scan blogs and articles on the web, or turn on the radio or television to hear stories about how consumers are getting caught in the middle of cost-shifting and cost-cutting strategies on the one hand and fees established by providers on the other. Due to a confluence of many factors, including these challenging economic times, the fervent debate regarding health reform and the pending Supreme Court decision, and the choice by some plans to move to a Medicare-based multiple for out-of-network reimbursement, to name just a few, the spotlight is now squarely on the need for healthcare cost transparency, as well as the need for fair and equitable reimbursement formulas. The headlines listed on this slide merely scratch the surface of recent items focusing on consumers trying to stay afloat with healthcare costs and expenses and the lack of transparency surrounding healthcare. And indeed, many of the articles and broadcasts feature the adverse impact on consumers as a result of using a Medicare-based formula rather than a UCR-based formula. The tenor of these articles and broadcasts and the breadth of their reach have started to cause regulators, policymakers, and legal officials to study more closely and systematically the impact of this conversion by some to Medicare and the absence of transparency regarding reimbursement practices. It has been fascinating to see the public and industry attitude shift toward greater transparency. We have received expressions of gratitude and support for the work we are doing in this space from consumers, providers, plans, and researchers, as well as federal and state officials. Our message from the start has been clear. Cost transparency is a win-win for all stakeholders in the insurance ecosystem. Effective transparency requires, in effect, a three-legged stool. One, educational resources to provide consumers with the vocabulary and fundamentals to appreciate and understand the key provisions of their insurance plans and reimbursement design. Two, market data for procedures by geographic region so that consumers can properly anticipate the charges they will confront when accessing care. And three, transparency tools to help consumers understand how provider charges factor into reimbursement formulas, whether they be UCR-based or Medicare-based, so that at the end of the day, the consumer has a clear appreciation for their out-of-pocket exposure. That three-legged stool will help consumers make sound enrollment decisions and help them manage their plan features, make EOBs a source of clarity and information rather than simply documents tossed away in confusion. That three-legged stool will also allow patients to make choices about whether to go out-of-network in the first instance, and if they do, to prepare financially for such services and avoid unwelcome surprises. In the end, such transparency coupled with education reduces the number of calls and questions posed to benefits staff and plan member services personnel, thereby materially reducing administrative costs and overhead associated with plan administration. So how did Fair Health become a source of cost transparency and robust market data? For those of you who are unfamiliar with our unique origins, Fair Health was created as a result of an investigation brought by then Attorney General Andrew Cuomo against the insurance market in New York. The Attorney General was looking into certain practices involving out-of-network reimbursement. In the course of the investigation, the Attorney General determined that there was an impermissible conflict of interest in the way in which out-of-network reimbursement was being calculated. The case was ultimately settled by all of the parties in 2009 for the collective sum of $95 million. The settlement featured certain key elements. First, it provided for the creation of a new, independent, not-for-profit organization. That new entity is Fair Health. We were established in October 2009. Next, it required Fair Health to create a robust database and enhanced data products to make available to the insurance industry in order to further the fair and transparent adjudication of out-of-network claims. Third, Fair Health was tasked with creating a free web-based portal which would allow consumers to obtain information about the cost of procedures and services they may access out-of-network in the specific geographic region where the procedures would occur. Finally, we were mandated to develop a research platform to support public policy, health systems, and health economics research. It should be noted that the settlement agreement required that Fair Health integrate the talents and expertise of academic researchers into the development of a new database. Accordingly, we partnered with a talented team of researchers who are known as the Upstate Health Research Network. In addition to working with the UHRN, we work with a national board of scientific leaders, including behavioral economists, healthcare economists, health policy experts, and the like, who further inform the work we do. Finally, one key point should be emphasized. Even though the New York Attorney General was focused on activities within New York when he launched his investigation into the healthcare industry, the settlement agreement resulted in a national remedy. That is, once Fair Health was prepared to stand up a new enhanced database under the terms of the agreement, Ingenix Corporation, which previously released benchmark data for the adjudication of out-of-network claims to insurers across the country, was required to stand down its benchmark data. Fair Health thereafter began to support this national market with fair, robust, and transparent products. What makes Fair Health and Fair Health data unique? It should be noted that we house the largest and most diverse private claims data collection in the country under the roof of an independent, not-for-profit institution. We have nearly 80 contributors nationwide who contribute data to our repository, and that number continues to grow as new contributors approach us seeking to be part of our contribution program. The data contributed covers over 125 million covered lives. At the conclusion of March 2012, we had approximately 14 billion distinct billed procedures in our database for the period 2002 to the present. That number continuously increases as the data gets refreshed and updated on a rolling basis. The data are organized into 491 distinct geozips in order to provide a rich granular roadmap to enable analysis and market use. A geozip tends to track with the first 3 digits of a zip code. And as mentioned earlier, we incorporate academic research directly into our work and data products. Thus, the Fair Health database, together with its underlying methodologies and algorithms, reflects the talents and expertise of the Upstate Health Research Network as well as our National Scientific Advisory Board. We also employ a comprehensive auditing and validation program to ensure that the data are complete and representative. We spent 2010 establishing our state-of-the-art technology environment, enhancing the database, refining the data products, and developing the consumer website. We went live in January 2011. We began our release of data modules at that time and also launched the consumer website. I'm proud to say that our website was recently honored at the White House Summit on Smart Disclosure. We were recognized as providing smart, actionable data to consumers to facilitate healthcare decision-making. From the time we went live in January 2011 until today, we have achieved extraordinary growth. We have entered into contracts with nearly 500 different customers nationwide, consisting of insurers, TPAs, bill review companies, employers, unions, and consultants who collectively insure or administer insurance plans covering over 177 million lives. Data is contributed to Fair Health by close to 80 commercial payers, most of whom have been in the program for many years, predating our acquisition of the data repository in 2010. We receive claims across the spectrum of healthcare services, including medical surgical procedures, dental, anesthesia, and HCPCS. The claims always include the non-discounted fee-for-service billed by the provider to the payer, as well as the location of service. Contributors submit data on a rolling basis, some monthly, some quarterly, or twice yearly, resulting in a continuously expanding underlying repository from which our data products are produced. Under the terms of the contribution program, payers attest to the fact that the submitted data represents the full set of claims for the submission period. Payers are not permitted to exclude claims. Upon receipt, all data are subjected to a rigorous validation process to ensure the highest quality throughout. For example, dates of service must be within expected ranges for each submission. Since the geographic component is essential to the data, we validate that the service zip code is a location at which services can be performed and not a billing location, such as a P.O. box. We check that modifiers are valid for procedure codes, that charges or units are not negative values, and so forth. Of course, all required fields must be present and valid. Once we receive and analyze the data, it is arrayed into a variety of commercial data modules. The modules we distribute include a medical surgical module, which includes CPT codes for medical, surgical, radiology, laboratory, and pathology procedures, as well as E&M codes. An allowed medical module, which includes fees allowed by plans rather than fees charged by providers. The data is available by plan types such as HMO, PPO, and an aggregate value. A dental module, which includes CDT codes. An inpatient facility module, which includes codes for services performed in a hospital inpatient setting. An outpatient facility module, which includes CPT codes for services performed in a hospital outpatient setting. A HCPCS module, which includes Level 2 HCPCS codes for products, supplies, and services not included in CPT codes, such as ambulance services, durable medical equipment, prosthetics, orthotics, and supplies when used outside a physician's office. and an anesthesia module, which includes CPT Category 1 codes, anesthesia codes, and surgical procedure codes. All of these modules are based on our private claims data collection, except for the inpatient and outpatient modules, which draw from CMS MedPAR and OPSAS data, respectively. We also create a variety of custom analytics that support the business processes and needs of our customers. Such custom cuts may isolate or aggregate specific geographic regions or clinical codes. Likewise, we can create a custom cut of market data that is juxtaposed with a second source of data, such as the Medicare fee schedule. In that instance, a data customer might be interested in understanding how certain percentiles of fair health data compare to a certain percentage of the Medicare fee schedule. While the original New York investigation and resulting settlement largely focused on the adjudication of out-of-network claims, our data products and consumer tools have had a much broader reach. In addition to supporting out-of-network reimbursement, our tools and products have become increasingly valuable to the management of consumer-directed health plans and the sound design of ACOs and bundled payments. Fair Health Data also serves as a strategic tool to help inform the negotiation of network panels and an important assist to human resource and health benefits personnel who have begun to see the concrete impact and advantages of shaping a growing generation of informed consumers. Our data and consumer content have also attracted the attention of a number of states as well as the federal government. We have a number of conversations underway with various states about how our data can support their UCR fee schedules, workers' comp and auto liability programs, anti-fraud efforts, and reform initiatives. We've also had an ongoing dialogue with the federal government about how fair health can help inform consumer fact labels, medical reimbursement data centers, and essential benefit design under the federal reform bill, a fruitful dialogue that we welcome. Commercial customers have also been intrigued by the ways in which our data can support fraud detection and adjudication dashboards. Finally, our data supports our research platform, which will be launched formally this summer and contributes to the ongoing support of our consumer website and educational resources. It has been heartening to see how we've become such a vital part of the national conversation on cost transparency and data integrity. As mentioned earlier, creating a free consumer website was the key element of the settlement agreement with the New York State Attorney General. The website is organized into 3 sections. The first section includes our educational content and resources, such as our original multi-part health insurance-related curriculum, which we call Reimbursement 101, which includes topics such as understanding anesthesia reimbursement, what is a flexible spending plan, the differences between an HMO and PPO, and so forth. We also offer a helpful glossary, instructive videos, and healthcare resources. The second section is our dental cost lookup tool, which allows consumers to estimate their dental costs for services nationwide, as well as to estimate their level of reimbursement for such services. Due to the high volume of out-of-network dental services, this tool has been particularly useful to and used by consumers. The medical companion to the dental cost lookup constitutes the third section of the site. The reception to the consumer website overall has been extraordinarily positive. In the last few months, we have had hundreds of thousands of page views. We are also encouraged that each visitor on average is spending approximately 4 minutes on the site, an eternity in this fast-paced cyber world. Since the launch of the consumer website, consumers have provided substantial feedback to us. We have learned that they're using the site in a number of ways. Some use it for the educational resources and videos that it offers in order to become a more educated consumer. Others use the cost lookup tools to make an initial determination as to whether going out of network is the right decision for them and to find out their potential exposure and whether they can afford such services. Some who have decided to go out of network or are managing their high-deductible health plans use the cost information to make informed choices when selecting a provider. Some use the site to negotiate with providers the cost of their procedure or amount of their balance bill. And now consumers are coming to the site to get clarity on the Medicare feature in their plan if their plan has converted to such a formula. Interestingly, when Fair Health was first created, the industry expressed some concerns about how the free consumer website would impact the marketplace and how it would interact with the data products released to the commercial market. Having had some experience watching the interaction of the products in the consumer website, I think it's fair to say that the data combined with the consumer website is a powerful combination that inures to the benefit of employers, plans, providers, and consumers. In this challenging economic climate, employers are looking for helpful ways to control and manage costs. Consumers have the same interest in managing their health care costs. By accessing the consumer website, employees and their dependents can make responsible decisions about their health care and plan ahead as necessary. By educating themselves and reducing the surprise of health care costs, employees are less apt to rely upon or complain to HR and other benefits personnel. Self-funded employers or health plans who use our data can also make informed decisions about reimbursement that dovetail with market indices. By engaging in fair and transparent reimbursement practices, employers and plans can help reduce the administrative burden and cost of numerous challenges and appeals by both consumers and providers. Our consumer tools and data can also be easily integrated into employee and health member portals in order to provide easy access to in-network and out-of-network cost comparisons and help manage consumer-directed health plans. Let's talk for a moment about the Medicare issue. That is the fact that some plans have begun using a Medicare-based multiple for the reimbursement of out-of-network claims as opposed to using a UCR-based formula that is tied to market data. This issue has attracted the attention of regulators, offices of the Attorney General, consumer advocacy organizations, provider organizations, and other stakeholders. While different stakeholder groups might have different areas of focus associated with this issue, all seem to agree that there is a serious lack of transparency with respect to the differences in values between these two methods of reimbursement. When studied and revealed, these differences are quite substantial, often to the surprise of even the most sophisticated employers and consultants. In some ways, there should be little surprise, as Medicare is a government-based fee schedule intended to address the care of the elderly, the disabled, and end-stage renal disease patients. The federal government embeds in this schedule certain policy decisions unrelated to market costs. Medicare was not intended to serve as an out-of-network fee schedule for the general population. A recent independent study prepared by Milliman juxtaposed Fair Health commercially based data with the Medicare fee schedule. It was prepared by Rob Park and Howard Kahn from Milliman. For those of you who have not seen this study, I think it would be worthwhile to review the next slide to illustrate the comparison of a Medicare-based fee schedule to Fair Health data. As you can see by this slide drawn from the Milliman report, they used Albany, New York as a random test case. Having selected Albany, they then compared various percentiles of Fair Health data to the Medicare fee schedule. From the table, you can see that at the 50th percentile of Fair Health data, you would have to use 270% of the Medicare fee schedule to gain parity on average with that percentile. Likewise, at the 80th percentile, which is used by many health plans as a frame of reference for UCR, you would have to go to 255% of Medicare to gain parity. As many of you know, when plans do use a Medicare-based multiple, they often use somewhere between 130 and 150%. As evidenced by this slide, using such a percentage would give rise to a Fair Health percentile well below the 50th percentile of market data. The next slide from a Milliman study illustrates several key points. First, it shows the differences in geographic representation between the Fair Health data and Medicare-based data. As previously mentioned, Fair Health uses 491 distinct geographic markets, which we call GeoZips. In contrast, Medicare uses approximately 90. Thus, the 8 New York cities listed on this slide would all be rolled up into one Medicare-related geographic market. In contrast, these 8 cities would be reflected in 10 different GeoZips in the Fair Health modules. That granularity becomes material when you look at the column on the right, which compares 140% of Medicare to the 80th percentile of Fair Health. That column shows the wide diversity in values between the different GeoZips when comparing Medicare to Fair Health, diversity which would be masked if using the broader Medicare GPCI framework. For example, 140% of Medicare would constitute 60% of the 80th percentile in Syracuse, but only 49% of the 80th percentile if the care was provided in Kingston, New York. As mentioned previously, the Medicare fee schedule embeds in it certain policies about the healthcare delivery system. It does not purport to be a window into market costs or charges. These policy decisions become apparent as you look at different specialties. In scanning this slide drawn from the Millman Report, you'll see there's a wide difference between how certain specialties compare to the 80th percentile of fair health in the Albany, New York region. These next two slides continue to show those various comparisons. Until the recent launch of the FH Medicare Compare tool on our website, which I will demonstrate in a moment, there was no available frame of reference for out-of-pocket exposure for consumers under a Medicare-based plan. This lack of transparency, coupled with the resulting surprise and hardship often experienced by the consumer, has been straining relationships between employees and employers and patients and providers. This lack of transparency and resulting consumer exposure are also triggering both heightened media scrutiny, as alluded to earlier, as well as legal and regulatory scrutiny into this reimbursement practice. We thought it would be helpful to show you concretely how the FH Medicare Compare tool works. This is a screenshot of a search seeking the cost of a colonoscopy in Hartford, Connecticut. We recently added a new feature to the site called FH Estimate Assist. Thus, instead of presenting the consumer with a professional fee for the colonoscopy, we offer to the consumer the opportunity to search for additional related costs, such as the cost for anesthesia and pathology associated with the colonoscopy. In other words, we assist the consumer with populating their shopping cart of potential costs. Assuming the consumer selected the related procedures, they would see this results page. This page essentially indicates to a consumer that if they were planning to have a colonoscopy in Hartford, Connecticut, that procedure together with the accompanying anesthesia and biopsy would result in an out-of-pocket expense of $702.01. That number is calculated by looking at the estimated charges for such procedures based on the 80th percentile in that area, and then taking 70% of that amount as the default. If a consumer's plan uses a different percentile or percentage calculation, the consumer could adjust the sliders on the site to tailor it to their needs. We default to the 80th percentile of fair health data and 70% of that amount based on a survey we did of common plan designs. Okay, this slide demonstrates the FH Medicare Compare functionality. It takes those same three procedures and analyzes them using a Medicare-based design formula. For the FH Medicare Compare tool, we use the same estimated charge since the consumer will still be confronted with those same level of charges. Instead of defaulting to 70% of the estimated charge, we default to 70% of 140% of the Medicare fee schedule. As you can see, we also include a slider to allow the consumer to change the formula to suit their needs. For example, if the consumer's plan uses 60% of 150% of Medicare, they can make that adjustment. However, using our default of 140% of Medicare and 70% of that sum, you can see that the estimated out-of-pocket amount for the consumer changes to $1,787.23. This slide makes the comparison between UCR-based and Medicare-based plan designs very easy. As you can see, under the Medicare-based plan design, the consumer will have to pay over $1,000 more in out-of-pocket expenses, a material difference that is now catching the attention of many. While we are delighted that consumers are using the website in steadily increasing numbers, we are also heartened that plans, employers, consultants, health systems, and other related healthcare companies are increasingly showing interest in leveraging our consumer transparency and educational resources. We offer free links to our educational content and cost lookup tools. We also offer free public service announcements in English and Spanish that can help direct consumers to our tools to assist with critical decision making. Some are licensing our content to embed directly on their own sites or brand it as their own. Such materials can also be disseminated at benefits fairs and enrollment meetings. Some license our data to populate their own transparency tools on member-protected websites. Some have discussed including a hyperlink to our site on their EOB forms to provide easily accessible transparency tools at no cost to the organization or to the member. We also can assist with creating a customized consumer hub that offers one-stop shopping for educational resources, cost lookup tools, and member-oriented materials. We're happy to entertain conversations offline to help create a transparency strategy designed to meet your own needs. I want to now take this opportunity to thank you all for participating in this webinar today, and we would be delighted to now take your questions.